Welcome, everybody. My name is Peter Roeleveld. I'm a pediatric intensivist from Leiden in the Netherlands. I'm co-chairing this and moderating this third pediatric ECMO webinar from EuroELSO together with Mark Davidson, a pediatric intensivist from Glasgow. And we have three excellent speakers for you today. We're going to talk about pediatric ECPR, the past, the present, and the future. Before we start, there's a few housekeeping details that I'd like to discuss with you. We're going to have three talks, and after the talks, we will have time for questions and a discussion. But you can send us your questions throughout the entire webinar via the question function in your control panel. Can I please have the next slide, Victoria? I also want to remind everybody that in May, we will have the virtual EuroELSO conference. This is instead of the actual Congress in London, and we all invite you to come and join us for this EuroELSO experience. Next slide, please. Today, we have three excellent speakers, like I said, and two moderators. Next slide, please, that will take you through to the next to the program that I will show you. We would like also, can you turn back one more, please, Victoria? Yeah. You can also please spread the news and follow us on Facebook, Twitter, and on LinkedIn. And there's also a possibility to view this webinar on the EuroELSO YouTube channel, probably from about tomorrow, 24 to 48 hours after this webinar. You can review this. Next slide, please. And the program for today, we will start off with Aparna Hoskote, talking about the current scene for ECPR. Then we will go into the different clinical settings for ECPR in children, and then how to train and simulate for optimal outcomes in ECPR. So first, I would like to please welcome Aparna Hoskote, who is a pediatric cardiac intensivist from Great Ormond Street in London, for her first insight and setting the scene for us for the remainder of the webinar. Thank you, Aparna. Please take it away.
Hi, everyone. Can you see my screen? Can you see my talk? Yes. Thank you. I'm just going to really say thanks to everyone for giving me this opportunity to speak here. I'm also going to have a very brief talk, really, and I'm just going to focus on the variability in ECPR provision, and I'm really going to set the scene for collaborative experience and learning. I have no disclosures. I'm part of the EuroELSO scientific committee, and I'm also the section chair for cardiac ICU and mechanical circulatory support in the ESPNIC. So I don't know how many of you have already seen this, but these are the updated 2020 American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, which have been published late last month. And here you can see the upper panel shows the graphic representation for in-hospital cardiac arrest, and the lower panel is for out-of-hospital cardiac arrest. And very importantly, high-quality CPR features very prominently. Now, I need to say this very clearly that good quality CPR or high-quality conventional CPR is essential before we can even contemplate a good outcome from ECPR. Now, the American Heart Association guidelines have not suggested any changes to the current recommendations, which were set in 2015 for in-hospital and out-of-hospital cardiac arrest in reference to the provision of ECPR. And they recommend that ECPR may be considered for pediatric patients with cardiac diagnoses who have in-hospital cardiac arrest in settings with existing ECMO protocols, expertise, and equipment. And this is evidence is class 2B, and You can see it's level C with limited data. Furthermore, it clarifies that if cardiac arrest develops in the child with heart disease and there is no prompt return of circulation, it is reasonable to initiate eCPR, and that eCPR can be most effectively deployed in locations with rapid access to ECLS equipment, skilled ECLS personnel, and adequate space to accommodate a large team. So you can see that all these factors are dependent on several prerequisites, and it is important that the team is well experienced, that there is a possibility of effectively deploying eCPR, there is rapid access, and there is adequate space to accommodate the large team. Now, this is an excellent paper. If you've not seen this earlier, it is a paper written by Peter Lawson and Anne-Marie Grigorian in Frontiers, published in June 2018, on establishing and sustaining an eCPR program. And they go through the various steps here in establishing the program. And you can see here, in relation to a cardiac arrest, they have defined intervals as to how you can effectively initiate eCPR. And you can see here that it starts right from, a -1 stage to a 4, where you have full flow and the patient is established on ECMO. So for a successful eCPR program, you need education and training, you need anticipation, and you need activation. And for this, your team has to be as experienced as possible. Now, it's very, very important that to have this in your program, in your institution, you have to have appropriate resources. And a paper by Javier Lassa, which I'd like to refer to, was published in 2018, looked at the standard of care in eCPR resuscitation in the pediatric cardiac population. They surveyed 150 respondents responded to this survey, which was distributed via PCICS, the PC4 Collaborative, and the ELSO. And you can see that the respondents, 89% of them were from America or Canadian, North American institutions. And what they found was there was a wide variability in resuscitative practices, including drugs given at the time of resuscitation whilst preparations are being done for deployment of ECMO, the logistics, the personnel, the training, all this during eCPR in pediatric cardiac population. And what they found was that there was differences between the team member presence in hospital 24 hours, or 7 days a week. And you can see here that 70% of the programs or the respondents said that they had an ECMO specialist in-house, whereas only 28% had an operator or a surgeon in-house. So 72% said that they did not have a surgeon or operator in-house. Furthermore, 62% reported formal multidisciplinary training programs for eCPR performance. And of those that reported training programs, only 59% reported use of simulation-based training that occurs at least once a year. Now, we conducted a survey, and this is an ongoing survey within the European Society of Pediatric and Neonatal Intensive Care of centers providing care for children with heart disease in Europe. And you can see here we asked questions such as, how many cardiac surgical operations does your center undertake? Predominantly, it was 200 to 350. The same for open heart surgery. The same when we asked for, does your center undertake all complexities of pediatric cardiac surgery? Predominantly, 85% said yes. But when we asked, does your center provide post-cardiotomy and mechanical circulatory support? Yes, again, that was about 95%. But when we asked this question, does your institution have an eCPR program for children? The answer was yes in 50%, and about 40% said no. So this was quite interesting for us, and we will have to delve into the factors behind this in more detail. But as of now, it's still ongoing, and we will be able to analyze this survey towards the end of this month. Now, to have good outcome from eCPR, you need to have excellent pre-eCPR resuscitation, you need to have efficient implementation of ECMO, and most importantly, you have to have an appropriate patient selection. So therefore, it's imperative that any institution which wants to have an eCPR program should reduce the barriers and allocate resources. We should have anticipatory decision making, as well as availability of rapidly deployable equipment and personnel. Furthermore, it's very important to bear in mind the cost and the ethics related to this complex clinical situation. We know that there is survival benefit from eCPR. The data on long-term neurodevelopmental outcomes is not very clear as yet. And so, to set the scene for collaborative experience and learning, I think it's very important that we have collaboration within the various societies. It's important to identify some key learning, and that is you should have a consistent and well-rehearsed system for eCPR. You should have the knowledge, the experience, and the resources to deploy eCPR. An optimal time frame has to be considered. Selected patient populations, very relevant to this provision of this very highly technical, resource-heavy therapy, and post-resuscitation care is very important. With this, I thank everyone, and I look forward to the next speakers, Malaika and Tim. Thank you.
Thank you very much, Aparna. That's absolutely fantastic. A really great start to the session and really sets the scene. What we'll maybe do is, as people wish to ask questions, again, as Peter said at the beginning, if you post them in the question board at the side of the chat, and we'll pick them up at the end. There's also a series of polls that will be launching through this as well, just to get the audience's thoughts and feelings. We're approaching 200 people attending so far already, and for those that have just attended, you're very, very welcome. We're recording this, so again, the recording will be available hopefully from tomorrow onwards on the EuroELSO website and the YouTube channel. So I suppose it's my delight to welcome Malaika Mendonca to speak next. Malaika's trained all over the world. She's trained in Toronto and Boston Children's, and she's now a senior pediatric cardiac intensivist in Bern in Switzerland. And Malaika is going to explore some of the background about eCPR and the different clinical challenges and knowledge base as to where we are. So Malaika, thank you very much. The floor is yours.
Thank you, Mark, for this kind introduction. I would like you to see my screen. Is that possible? I don't see my screen, Victoria.
Your screen is there. I can see it, Malaika.
But I can't.
Do you want to move forward and see if I'll tell you if it moves forward?
No, I don't see. I just see. Sorry, I have a technical problem here.
Just while we're waiting for that, there's a question just at the side there while Malaika sorts out her presentation. So there's Tariff is asking if there's any added incentive that ELSO provides for institutions to conduct regular simulations, for example, acquiring different status levels within the program. As far as I'm aware, a key part of the different center status is about having an in-depth education program, and I think the absolute advice from ELSO is that should part of that should be simulation. It's being very much built into the ECMO Ed or the education platform that ELSO is really promoting elsewhere in the world. Malaika, are you okay if we come back to you then?
Okay. Yeah, I see. So you guys can see my screen, and I would like again to thank you for inviting me to talk at this challenging task. How do we do an eCPR in different clinical settings in children?
Malaika, so sorry,
yeah?
I can't see your slide.
Yeah.
We can't.
See moving?
We cannot see your slide.
Oh, I thought it. Show my screen again. Let's see.
Yes.
Okay, then yeah, okay, so let's try. You see my screen?
So go into slideshow now, and that'll be you good to go.
It's okay now, you see?
Yep, excellent, thank you. Moving? Yes, fantastic.
Thank you, sorry for the technical difficulties. I hate this virtual world. I like to see you all in person much more. Okay, so let's get started. The first reports of ECPR in children date back to the 80s, where this group here had a study period of about 10 years, and of course it was very new, so they only reported 11 patients who went on ECMO via ECPR. But they had a quite nice successful rate of 64%, and they already concluded it might be a feasible option in selected patients to go on ECMO after prolonged CPR. And at this point in time, they were even talking of longer than 60 minutes. So where did we go from there in our days? If you see, this is data from the ELSO registry about annual reports on neonatal runs. We have a steep increase on ECPR on neonatal runs. The same if you look at the pediatric ECPR runs, also they are increasing quite significantly. But this data doesn't tell us which patients are those. Are this in-house hospital arrests or out-of-hospital cardiac arrests or any arrests? So in this session, we will speak a bit about in-hospital cardiac arrests with patients with cardiac diagnosis and about in-hospital cardiac arrest without cardiac diagnosis. For out-of-hospital cardiac arrest, we will discuss some data and about ECPR and accidental hypothermia. So as Aparna already mentioned, the earliest recommendations of using ECPR are coming from 2015, and it says it may be considered with patients with cardiac diagnosis, and there was insufficient or no for or against use of ECMO in patients without a cardiac diagnosis. So that's 5 years ago. And Aparna said already to you guys, there's nothing new in the recommendations from this year. So haven't we gathered any data, or why is that? So when we look further into the literature, this is a nice systemic review I would all encourage you to read, published 2 years ago in Resuscitation. And that's a systemic review. And they looked on all published data on ECPR in adults and in children. So for the adults, there were much more studies, case reports, and so on. And for children, there were only 3 pediatric studies on in-house cardiac arrest, none of pediatric out-of-hospital cardiac arrest. And they came to the conclusion that there's no evidence for either support or refute the use of ECPR for out-of or in-house cardiac arrest for adults or children. So then my question, why should we do it? What are we talking about? And what are we doing now? So back to the ELSO registry data. When you look at, this is now the data from accumulative runs, they are over 2,000 now reported. And when you look at the neonatal ECPR, there's still a survival to discharge or transfer rate of 42%. The same for the pediatric ECPR, over 5,000 runs totally reported, and quite nice survival to discharge or transfer rate of 42%, compared to the adults, where they have 29% only of survival. Of course, we ask ourselves, why is that the case? What are we doing differently in pediatrics than the adults? And then we look a bit deeper into the data, also from the ELSO registry. This was published in 2016 about all these runs from 2011 to 2015. And when you look at where those things occurred, it was mostly in the operation room or even more in the ICU. Yeah, so almost 80% were in highly monitored areas. And also most of them, yeah, 94%, they were witnessed. And only 2%, about 37 cases, were out of hospital arrests. reported. And that's, of course, a big difference to the adult world, where they cannulate nowadays in front of the Louvre and may have a bit of worse outcome with this. So for the in-house cardiac arrest, it is really, really important, as Kalpana also mentioned beforehand, that we select our patients quite carefully. And we should have even a pre-arrest discussion, and even better, having indications and contraindications set in protocols for a potential cardiac arrest, to avoid discussions and wasting time when it comes to decision making. So do we get any help here, which patients to select from the guidelines? Here's a statement from the American Heart Association about cardiopulmonary resuscitation in infants and children with cardiac diseases. This is published in 2018. And they're still very vague, these statements. ECLS may be considered in patients even before cardiac arrest. It is reasonable to initiate ECPR in children with cardiac disease. And as we heard before, ECPR can be effective, and it should be deployed in a location with rapid access. So that is a bit of a vague statement, and it's mostly for cardiac kids. So we could ask ourselves, why is it beneficial for cardiac kids? And when you look about the physiology of our high complex cardiac children, maybe those underlying anatomy or pathophysiology has limited effectiveness of conventional CPR, like a limited stroke volume with chest compressions. For example, when you have massive AV regurgitation or restrictive myocardium, or limited effective pulmonary blood flow with a RVOT obstruction or elevated pulmonary vascular resistance, or even on the cardiopulmonary connections, or if you have aortopulmonary runoff across shunts. But also those ECPRs are, or any ECMO flow, even if it's not an ECPR, extremely tricky, and you have to have a good look into the pathophysiology, especially when it comes to aortopulmonary runoffs and shunts. And we have briefly touched on these even in an article published last year in Frontiers of Pediatrics. So let's move on to the non-cardiac disease kits in pediatrics. There are no recommendations for or against. Okay, let's make a case. Yeah, we have our refractory hyperkalemic cardiac arrest in a child with tumor lysis syndrome. Or we have a cardiac arrest in a child with an end-stage pulmonary hypertension who is already listed for transplant. These are usually children, they are in a highly monitored area. They are approached by a multidisciplinary team, and they should be discussed and probably selected for potential rescue ECPR in advance. So I'm not saying ECMO can cure all diseases, but in selected cases, we have to be aware that it even can be useful to initiate in a non-cardiac disease in pediatric patients. So, of course, we all ask ourselves about the prognosis. What do we tell the team? What do we tell the parents? What have we done? Was it any good? And then I want to refer to this paper published last year in Pediatric Intensive Care by a Swiss group who made a really simple scoring system, which just looked at the length of the CPR, the lactate, and the pH. And for each of the three components, it gets some point. And when the point value was greater than 9, the predictive value for mortality was 94%. And of course, it makes completely sense. It's physiology. We all know that lactate and pH reflect the quality of the CPR, or it may even reflect beginning multi-organ failure. And of course, we all know longer runs of CPR lower the chances of survival. But of course, further collaboration and studies would be necessary to validate this scoring system. So this study and many other studies show that it's crucial where the timing in between starting eCPR and going on to ECMO. And I think Tim will go much more deeper into it in the next talk and emphasize on training and being ready and so on. And I just wanted to show you again the data from the report from the ELSO community, which showed that mainly the cannulation location was the ICU. And that seems to be a very, very good location because you have rapid availability of equipment and resources and a large enough space to do so. So let's move on to out-of-hospital cardiac arrest. As I've mentioned earlier, there are no studies on eCPR for out-of-hospital cardiac arrest in pediatrics. There are some case reports existing, but certainly no studies. So what do we know about out-of-hospital cardiac arrest for children? We got a lot of information from the therapeutic hypothermia trial. And there we can see that out-of-hospital cardiac arrest in children is mainly due to respiratory arrest. Only 12% to cardiac and a lot of unknown. And the initial rhythm is to almost 60% asystole. And only 1/3 of the arrests are witnessed. So that's a great difference to what we've learned from the in-house cardiac arrest, etiology, rhythm, and witness type. And also the people found, of course, no surprise, better survival and neurological behavior outcome with a cardiac etiology, a shockable rhythm, of course, shorter durations of chest compressions, fewer doses of epinephrine, which of course concludes in earlier return of circulation, and of course in witnessed cardiac arrest. So no surprise here, but no data ongoing on eCPR. So what about accidental hypothermia? Accidental hypothermia can happen in a very cold environment in the Swiss mountains in wintertime, but it can also occur with impaired thermoregulation, for example, with alcohol or drug abuse, in traumas, or in extremities of age. And then we have the special case of drowning. Yeah. In drowning, the crucial factor is whether the brain hypoxia occurs before the protective brain cooling takes place. And usually 2 to 5 minutes have a pretty good outcome, greater than 10 minutes have a poorer outcome, and 25 to 30 minutes have no chance of survival. But here and there, we see the miraculous survival or the good recovery of small children drowning in very icy water. And that might be due to less subcutaneous fat on higher surface body area, which leads to faster cooling than asphyxia occurs. And swallowing the cold water is supposed to cool the heart, the carotid arteries, and the brain. And the smaller head might cool faster as well. So published guidance for those cases is to urge aggressive out-of-hospital and in-hospital treatment in the absence of obvious indication of death like rigor mortis. So when we look about the hypothermia, there is an update published in 2016 for adults and children, and they state clearly that the management of accidental hypothermia and guiding decision-making out of hospital is extremely, extremely difficult. And no one is dead until he's warm and dead. And the decision to withhold ECLS is best made at the receiving hospital. Easier said than done. So who do we put then on ECLS warming and who don't we put on ECLS warming? For this question to be answered a bit better, the HOPE score was developed. HOPE means the hypothermia outcome prediction score for ECLS warming. And it's based on 6 variables: age, sex, presence of asphyxia, potassium, CPR duration, and temperature. And it's an online available tool, and I will show you in a few seconds how that works. And this HOPE score was validated, and the validation was published last year in Resuscitation. And the negative prediction value was 100% for survival for a score less than 10%. Means when you score below 10%, your survival rate was 0. Until this happens. They had a child, 7 years, gender, male, hypothermic with asphyxia, CPR duration, 71 minutes, potassium of 6.6 and a temperature of 27.5. So this is what you give into the HOPE score online, and it calculates the possibility of survival at 4%. So this child survived with a cerebral performance category of 1, means a very, very, very good outcome, and of course lowered the negative prediction value in this review to 97%. In summary, for in-hospital cardiac arrest, there is some evidence that for well-selected patients, CPR is beneficial. And good quality CPR and short time to go on to ECLS is substantial for a good outcome for both survival and neurological. And we will go on to the training and the settings in the next talk. And for out-of-hospital cardiac arrest, there's very little data available for pediatric out-of-hospital eCPR, and there comes in what Aparna already said. We should collaborate, share experience, data, whatever we can do to get more information on that. And hypothermic patients are special cases and need special considerations. The best is procedures, protocols, checklists, and team training to help to reduce time to ECLS. And we need to work together to provide further guidance in the future. So with that, I want to lead you to a case discussion. You have a 2-year-old child who is playing outside in the farmhouse in winter, and mom and the older sister are taking care of some animals. It's a nice farmhouse setting far away. The mom noticed that the small child is missing. She finds the little girl head under in a drinking container for cups. No breathing. They activate the EMS people and they start the lay CPR. The EMT team brings the child to our emergency room under CPR. The underlying rhythm is a bradycardia with 48 beats per minute. The core temperature is 32.5. Would your team, would your people go on ECMO? Please, can we have the poll question, Victoria? It's an interesting case, and I don't know how many people have these settings where those things can happen, but I think we all need to be sure that we have a plan in place if some patient like this comes into our emergency room. And this is always a very, very stressful experience to decide on such a small child. Do we go ahead, do we not go ahead? And their simulation and training and discussion and debriefing is very important. We still give it a few seconds for the poll, or are we done? Victoria, can we see the poll, or I don't see?
Can you see the results? So actually, they are displayed already in the full screen. So 68% answered yes, and 32 answered no.
So 2/3 say roughly yes, and 1/3 would not. Okay, of course, this is an eCPR seminar, so we went on ECMO with this child. After 2 hours in the ECMO run, the temperature was up to 35.6. We had a sinus rhythm back with a heart rate of 95 and nice pulse arterial flow on the ECMO run. 3 hours in the run, the nurse noticed dilated pupils. An instant CT scan showed massive brain edema with herniation, and we decided to terminate the ECMO. We were counseling with the family and discussing organ donation, and the family agreed the ECMO was weaned and all the organs were donated. So there are, in summary, many questions to still be answered. And we have to all be aware, if we go the full 9 yards and we do eCPR and it turns out to be futile, solid processes must be in place to end the ECLS support. And if in the case of an isolated brain death with unimpaired other organ function, bridge to donation could be a consideration. And I thank you very much for your attention and would pass on to the next talk with it. Thank you.
Thank you very much, Malaika. That was absolutely fantastic. Just while we're summarising here between Peter and myself before we move on to Tim, can I ask the audience members, we're just going to launch a second poll to get people's thoughts about whether your institution offers eCPR round the clock, so 24/7, 7 days a week, 365 days a year. Feel free to answer that as we go through, and I will just give you a few minutes just to answer that. Can we just share that again, Victoria? So we'll give you a second to answer that. Can we open that back up again, Victoria?
Start over, if possible.
Just give me a second.
Thank you very much. So just maybe while we're give you a chance to think about that and answer that over the next minute or so. I think it's fantastic to see we've got people from all over the world dialing in here. Just there's a question from Yingyu from Shanghai. Welcome. Malaika, just a quick question. There's about target temperature post eCPR and how we manage any impact on heart rate. What would you target, given your reading of the current literature? How would you manage temperature after an eCPR? And let's imagine this is an in-house cardiac arrest. What would you target in that situation? Would you target hypothermia? If so, what? Would you target normothermia?
Well, that's a very good question, Mark. Thank you for that. As we know, the current guidelines say avoid hypothermia. Yeah, so that really depends. If we have a child who is not on ECMO, as not on eCPR ECMO, we would target for normal temperature, low normal temperature, not above 36. Because of the hemodynamic impairment hypothermia can have on the body. But when it comes to patients on eCPR, and we have, for example, we had a few hypothermic children coming in, we keep the temperature low for at least 24 to 48 hours, which means 34, 35 degrees. Not lower, because you have a lot of side effects when you have lower temperature, like the coagulation profile, which can be impaired and so on, which is always a problem when once you are on ECLS support as well. But there's no real evidence data available. This is just a practice in our hospital.
That's fantastic. Thank you very much, Malaika. Just to close off that survey, so about 2/3 of you voted in there, and about 2/3 of you say that you do offer eCPR 24/7, which I think is really, really interesting, that over a third of centres don't do that, or a third of respondents don't do that. So I'm going to pass over to Pete for the next section, and we can pick up the questions as we move on. Thank you.
Thank you. I was interested in the results of the last question. I thought we were going to also ask about whether that means people have 24/7 in-house coverage for eCPR, but we can maybe do that at the end. Let's go on with Tim Antonius. Tim is a neonatologist from Nijmegen in the Netherlands, who is a guru on ECMO simulation and has a broad knowledge about this and is willing to share that with us. So I would really like to invite Tim for sharing this with the community. Tim, so the floor is yours.
Thank you, Pete, for calling me a guru on ECMO simulation. That's the title I never had before, but thanks. What's true about this is that I'm a neonatologist, so I'm a bit of a stranger, I think, in this world, but I'm used to it. And I'm involved in ECMO simulation since 2007, so that's quite a long time. And I was really glad really honored for the invitation to talk about ECMO simulation, and mainly in using ECMO simulation to improve pediatric eCPR outcome. And that was an ambitious title because, first of all, we have to use ECMO, talk about ECMO simulation, and then about eCPR, and then connect those two, which isn't that it isn't being done in all centers, I saw in the first talk. So first, I'm a neonatologist. We're in one of the ECMO centers in the Netherlands, and my job is mainly respiratory ECMO neonates, but in our hospital, our cardiac cases or pediatric cases are also managed at our ward in our ECMO team. I have one disclosure. I'm an inventor of a parallel ECMO simulator, which is marketed by Chalice Medical, and I do earn some money when you buy that machine, but that's my disclosure. I have no other disclosures. So from an ECMO simulation, or from an educational view, eCPR is one of the most interesting and most challenging tasks there are in our hospital. I'm still, after maybe 13 years, still struggling with ECMO simulation, how difficult it is and how many things have to happen, and how teams work and how you deal with all those teams and to provide an optimal outcome. And even then, the data for ECMO simulation as for improving outcome in patients is really limited still. I thought maybe we could use my experience as an ECMO simulation enthusiast. I don't use the term guru anymore. Why eCPR is so challenging? Because it's ECMO plus, and we have a severe time pressure thing, meaning Malaika showed already in a study, and also in a study by Wang, which is at the bottom of the screen, longer CPR time before eCPR and higher pre-CPR lactate levels are associated with poor outcomes. Meaning, if we think about training and improving outcome, this time pressure, this longer CPR time is maybe one of the targets we can have in mind. Then there are a lot of tasks being have to be done to put a child which is being resuscitated, to put it on ECMO within some time frame. And there's a very nice article about our American colleagues, Lillian Su, which is the references at the bottom, which described ECMO simulation and eCPR, and they actually looked at all the tasks which had to be done, and they identified about 90 different tasks which need to be accomplished before a patient can put on ECMO during an ongoing CPR. Imagine that, 90 tasks. So, and that didn't include ECMO system assembly or those kind of things. So think about maybe your last simulation session where you practice all kinds of resuscitation routines, but think about this massive task management job you had to do. Then you have the teams. There's one team. You have most of the time you have at least 3 teams, meaning your ICU team is doing, I hope, high quality prolonged CPR, and that high quality is probably essential. And the often prolonged CPR, I'll get to it somewhat later. And you have a surgical team which have to perform a cannulation procedure, which is not always straightforward, especially in these kinds of really high time pressured, chaotic scenes. And we have our ECMO team managing an extracorporeal circuit. If we look at all the roles, it's in the same article from Lillian Su, we have about 16 different roles they could identify in their ECMO eCPR program. 16 different roles, meaning there are 16 different people having a specific role, and they have to perform those 90 tasks. From a simulation point of view, this is a massive challenge. Then we have the logistics, which is an extra complicating factor, meaning you have to get some guidelines in there, because which patients are you going to put on ECMO, who to call, does my blood bank know when I call I have an eCPR what to do, which patients are actually eligible for eCPR. Like the guidelines said, you should consider it in cardiac patients, but mainly the other patients are probably not the best idea. Do we have an agreement in our hospital to do that? Talk to your facilitating services like the blood bank and how to deal with this and incorporate them in this really time-pressured situations. Then you have your 24/7 availability of eCPR capable staff, which is not always the case. Location, there was a small mention in the first talk about the room, but the room is essential. Where do you do that cannulation during eCPR? And lots of different questions in equipment. If you have to think about all your equipment in these time pressure situations, you are having problems. So we have a very complicated situation where task management, proficient skill, you have to have proficient skills. You have a lot of people, a lot of different roles, and we have the logistics, which actually are in some cases really limiting the performance of a team. So if we think about how we can improve that, I thought maybe we should look at a target for our training. So can we identify something in eCPR which actually matters, which is if we improve this, it's reasonable to think that our survival and I hope the outcome eventually will improve. And can that be targeted by training? So we had some slides from Malaika before this. I have my own, there's some studies here which actually show you, there's a study from Siravayan, if I pronounce it correctly, it's quite old study in intensive care medicine. It's the minutes of pre-ECMO CPR is actually associated with people who are resuscitated longer before start of CPR actually having a worse outcome. But that's not always the case. This is another study from Brunner, which actually also shows a trend where you can see that CPR duration is actually associated, and it makes sense to think that it is. But not all studies are showing this. So this is a study from Melvin and co-workers where the CPR duration wasn't associated with poorer outcome. But if you look at the duration before of the CPR, it's actually in the minutes, in the 26 minutes, while in the other studies it's about 40 minutes. And I think it's really impressive to go on ECMO in 25 minutes in eCPR, but that might be the explanation why this difference doesn't matter here. There you in the line above that, you can see that primary cardiac pathology is probably the better group of patients to put on the ePCPR. So, and there are a lot of other studies like Malaika showed one, and there are several other studies showing that it might be a reasonable target to shorten time to ECMO and perform excellent CPR and do patient selection as our targets for our training. So I always like to think about training and setting a target, what do I want to improve? I want to improve team management skills, or I want to prevent adverse effects. I want to make sure we don't harm the people, of course, but what do I, at the end of the day, the end of our training, what needs to be evaluated as improvement? What will be improvements? And shortened time to ECMO is actually a quite reasonable one, which you expect to improve prognosis, and is also easily you can measure it. So if you look at the nature of our eCPR, you can say, okay, the complexity, the time critical, and the high pressure nature of the pediatric eCPR, that seems like that simulation is a good idea. Just to take you back some years, this is 2008 ECMO simulation, where we this is our first ECMO simulator, and that's just to guide you some that ECMO simulation is now provided in a lot of centers, but back in the days it was difficult to do. Simulation was just starting up, and ECMO simulation was like the most difficult thing to do at that time. Now a lot of centers are doing it, but look at our simulator. On the left, you can see we mixing 220 volts with fluids. That wasn't a good idea. Then we had a fish tank pumps to inject some air in the circuit, and we had a bladder, which we actually connected to the ECMO circuit, and we could do all kinds of things with these things. And that was our first ECMO simulator incorporated in the simulation program. And we went on a lot of trips. And this is one of our trips in 2008, where we had a big accident and all the blood, the fake blood was spilled on the floor. And we had a lot of a good time with this. But our ECMO simulation program came from this simulator, primitive simulator, to a full-grown ECMO simulation program, where we now have a quite elaborate setup, where we have an ECMO simulator. The patient is actually on a ventilator on the ECMO machine. We have patient monitor simulators, a medium fidelity mannequin, so we can do all kinds of. And we in the years we discovered that we needed these somewhat more high fidelity simulation to prevent the distracting factors of not being real. This is not the real world, but for us in this stage of ECMO simulation, it's good enough. But what we find out in a very early stage is that you can do a lot of technical skill training. You can do a lot of fancy things in your ECMO simulation, but in essence, you train your team. And you train with a team, and this is one of our slides we always use in our crew resource management part of the course, where we train our teams in very different domains than only practical skills training, where you can see that there are different domains. I mean, I can talk all day about these boxes, but these are things which don't have anything to do with it, whether you not can put in a cannula, whether or not you're doing ECPR right, but this has everything to do with how to manage that supercritical situation effectively and safely. But that's the hallmark of our crew resource management, is to act effectively and safely for the patient. And if you're looking at ECPR, then we have a lot of things coming back in these different boxes, because we have the logistics and the team communications. We know we have a lot of stress management. There are there's a multidisciplinary team, so there's a group dynamic problem. Certainly we have problems with leadership in these three powerful teams. There are decision-making issues and time pressures, and also there's a really risky environment where you have to assess risks. So ECMO simulation can, with the emphasis on these kinds of processes, can actually improve your team. Is there anyone who has ever really looked into this and using simulation for ECPR? And that's the article I referred to somewhat earlier already. It's done in the United States by Lillian Su, and they actually did this. But, and I really recommend this paper. There are some prerequisites for doing, in my view, for doing ECMO simulation in the ECPR. Because we can do a lot of ECMO simulation, and most of the time in ECMO simulation, we practice the things that the ELSO actually advises us on doing emergency training, like air embolus or no flow states or bleeding, or but in ECPR, the problem is if our target is to reduce the time to go on ECMO when you're on ECMO, then we have to think about other things we have to put in place before we go into the simulation lab and test our teams and our guidelines. So we have to I would really stress to that you map all the tasks and the role in your multidisciplinary working group, because if you're starting or already doing eCPR, it might also be a really good exercise to look, okay, who's involved, what is the different tasks, what's the different responsibilities, assign those tasks to the different roles. You can practice several technical skills in wet labs for cannulation. I'll get to that somewhat later, but also do really good CPR. You can practice that in skill stations and in wet labs. Do that because there are some literature which also always suggesting that if your technical skills aren't up to standards, your team skill will suffer. So practice your technical skills. You don't need to do simulation to do that. Include your facilitating services, and I mean like the blood bank in these pre-simulation, pre-training phase. It sometimes helps to write in detail what's the calling, the paging map. So who you're going to call when you on a eCPR, which is the next call, who's in charge, and do a prospective risk analysis. Okay, what can happen? What's the worst case? What can happen? What can happen if I have to do eCPR in the emergency room and I have to transport the patient to the ICU? Really stupid things can happen, like I can get into the elevator with my ECMO machine, with the Peter kit on ECMO machine. That happened. But several other things, how the logistics is mainly the problem in these kinds of things. In your simulation phase, this is a multidisciplinary event, so it makes sense to do a multidisciplinary team training and practice the whole event, meaning there's a resuscitation, and I would always start with in-house resuscitation and do the real call. So practice everything, and so the whole event. Measure your outcome parameter, and in this stage, just measure how long does it take to that the ECMO is actually starting. If you have the possibility, do the in situ simulation session, because we talked about the logistics, which is actually really important in this eCPR. Do in situ simulation, meaning that you have the room where you agreed on where you're going to do this. Then you look in your simulation session whether or not this room is sufficient, proficient. Does it have all the right tools? Is it, and you can improve on that. Brief and debrief is in the simulation world, of course, always do this. And in these kinds of multidisciplinary team training with really experienced people, have a good experienced debriefer. And the last one is watch the logistics, because the logistics are, you can use ECMO simulation and in simulation in general to watch the logistics, to find bottlenecks you didn't actually expect in your process. Then your tools, simulation experts are actually like their tools quite a lot. Me too. But if you think about what you will need, is a patient monitor simulator. It can be a fancy one, but it can also be an easy, just a basic one. A mannequin with an airway and chest movement is I think the minimal you should have. The cannulation procedure is actually one of the core procedures during the eCPR, and one way to put to somewhere to actually do the cannulation. Maybe it's not, we are not there yet that we have a really good cannulation simulator, but somewhere that you have to have your surgeon take that appropriate cannula and stick it into the patient or into some kind of simulator. Actually doing this and connecting it to the ECMO circuit will give you some valuable information and training. You need your own ECMO machine. You need to have cannulas, crash cart medication, and video, especially logistics and you can only pick up on some things at the same time, and video will be really you can't do without. If you're going to go somewhat more sophisticated, then you can have a cannulation simulator. There are someone, I will show you some pictures. There are about 3 commercial available ECMO simulators, which in essence all do the same. You can limit venous and arterial flow. You can put in some air bubbles. You can manipulate the pressures and have some bleeding. In essence, they're all a bit the same. Some is more costly than the other one. These are the Eigenflow simulator. This is the Califia simulator from Biomed, and this is by myself developed a parallel simulator which is marketed by Chalice. In essence, they do the same. There are some tools on the market for if you want to do somewhat more high fidelity cannulation simulations. You can go to the 3DMed website to look at these mannequins. One of my colleagues just published a paper where a really low fidelity cannulation simulator, but it's actually being experienced by the surgeon. That's a really good cannulation simulator. So, but you can also build them yourself. Does it work? Does ECMO simulation do we have some evidence that all this effort going into ECMO simulation does actually do what we think, what we hope it will do? This is an article from Lindsay Johnston, where she looked at simulation for neonatal ECMO teams, and this is actually referring to the other article. And in that article by Lillian Su, the teams actually did the whole thing. Just looked at the tasks, the roles, mapped it, did the preparation really well, and did 8 simulation sessions also during day and night. And they saw a result in real patients. So in the pre-intervention group, the time to go on ECMO was about 43 to 60 minutes. And in the post-intervention, meaning the ECMO simulation program, it went down to 40 minutes, from 51 minutes to 40 minutes. So our target, which was sensible as a improving outcome target, was actually being achieved. There are not a lot of other different studies who actually looked at this specific parameter in real patients. So we need data on this. In conclusion, ECPR is a challenging treatment modality, which is much more than only team training and skill training, meaning there is a lot of logistics going on, which need a thorough review before you start doing training in multidisciplinary training. Otherwise, you'll be frustrating your team and you won't get results. Simulation is probably the best tool to do to test your team and the skill proficiency of ECPR. And yeah, we have some evidence that in real patients you can reduce time to go on ECMO if you do your simulation sessions right. That's what I'd like to tell you, and thanks for your attention.
Thank you, Tim. Excellent. Thank you very much. There's some questions coming through. I would like to start off with another poll. Victoria, if I may ask you to load up question number 3, which is how many of the attendees, how many of the listeners have a simulation program for their ECPR? We'll just wait for the numbers to grow.
I think 90%.
What do you think? No, it's what I expected.
Yeah.
About a little over half people have voted, and the majority, 2/3, are saying that they do not have an ECPR simulation in their unit.
Really?
And that's interesting. I want to ask Tim, in the meantime, while we are waiting for the poll, how do you get, maybe this is one of the challenges, I think, how do you get, all the buy-in from different parties, the OR team, the surgeons, the intensivists, maybe anesthesia? Maybe that's more the problem for simulating CPR. How do you get the people to buy in?
Yeah, that's the. Oh yeah, that's that's a good question, Malaika. But that's an overall simulation question, especially in the intensive care, high pressure, or the multidisciplinary team training. It's almost impossible to get all the people in there, but if you can show them that this is a reasonable, if you involve them in the planning, so in the first stage of the writing out your ECPR program, and I'll have ECPR the same as your ECMO program. So if you involve them, you involve your surgeon in developing your curriculum, I think it will be much better. So you have to do it in advance, and we didn't do that right in maybe in 15 years. We just started our ECMO simulation from our ICU, and we struggle immensely to get the people in there. But also they're not actually involved. We ask them to show up, but we're not asking them to help us to write a guideline and to think about how to do this. And I'm sure that will get more involvement, and that's maybe the key to getting more involved. But it's immensely difficult to do this.
Yeah, I was wondering if, because we asked the question if people do regular ECPR, but maybe that's too specific for ECPR, and I was wondering if people do regular ECMO simulation. I'm sure that number should be higher, but I don't know if it's possible for Victoria to make that question in the meantime.
For sure. Would you repeat it, please? Then I'll add it.
So the question is more general. So do you do ECMO simulation? So not specifically for ECPR, but just general ECMO simulation. And I'm just hoping that that number will be higher, because maybe people find it difficult to organize specific ECPR training. If you do not have an ECPR program, you won't do it. That would make sense.
Just while that's running, I maybe ask Tim's simulation expertise as the sim guru here. The current times make it challenging for everyone to get together and train as a group. And ECPR, as you and Aparna and Malaika have demonstrated, is a hugely complex situation. What's your feeling from team learning about dividing the different aspects of ECPR training up into manageable chunks? So you're doing a 10 to 15 minute session on getting the theatre tray ready, getting the kit round to the bedside, doing bedside CPR simulation. What are your thoughts on that and the benefits to the team of that, Tim? Worthwhile, not worthwhile?
I think yes, training will always improve your team, but to put everything together, that's the problem. I think yes, it will be worthwhile to maybe get your example to train how to assemble that tray, but it may be much more worthwhile to make sure that tray is already there. So the planning phase. CPR training, we've done that for years and years now. You can train teams to do CPR in a regular basis, and yes, I think it's really good to do that much more often in small chunks, and maybe instead of doing this once a year or once in the 6 months. So for CPR, for technical skills, yes, I think you can do that because you need those skills. If you do an ECMO simulation, let's talk about, maybe make it somewhat broader, ECMO simulation. If those skills aren't up to par, then your ECMO simulation will fail. And for this, my answer should be yes, you can divide it up for your skills in small chunks, do it often, and then you can use that in your big simulation session.
So how often do you do ECMO simulations then, Tim?
We have ECMO simulation about 5 or 6 times a year.
Yeah. You can see that the people have responded to this question that indeed many more centers do regular ECMO simulation, but still not everybody. Thanks, Victoria. Yeah.
I think maybe I can elaborate on that. ECMO simulation is always a bit on emergencies, and we know emergencies on ECMO have a really high, have a poor outcome. So there's one number we always use: about 25% of the patients die when you have one of the real emergencies on ECMO. I don't know if that's really true, but it's still true. And we train emergencies because it's in the manual. But one of the things we started to train more and more is basic physiology in an ECMO simulation session. So we have a low blood pressure. It's not problematic, but we have a low blood pressure, or we have oxygenation problems, or our ECMO machine is actually a really low negative pressures on the venous side. It's not an emergency, but in a simulation you can do a lecture, but in the simulation you have to integrate all that knowledge and communicate it with your team. And that's actually one of the things we're using ECMO simulation much more and more to do that. For eCPR,
right?
Sorry?
For problem solving, not only the emergencies like air bubbles and pump failure and this kind of things,
yeah.
Right?
Yeah, and you don't have to have a really fancy simulator to do that. And I think people sometimes forget that simulation training is not a resuscitation training. It's to integrate all your theoretical and your practical knowledge to manage your patients. And you can see really beautiful team performances and helping each other and look at that thinking process in simulation. You can use it for that. For eCPR, I would use it in the other modality as looking at how do I get my logistics ready so I can put this kid on ECMO as quickly as possible. And you can use it for that too.
So Tim, I had a question for you. You very nicely showed in your presentation the papers by Su et al, where the personnel needed and the task orientation, the number of tasks. It's incredible, isn't it? 90 odd tasks and 16 specific roles. But at the end of the day, you need a leader at the bedside who is managing this eCPR process. Do you think, in your opinion, that there should be separate training for the leader? How should an individual lead such a big group where there are 3 different teams trying to put this patient on ECMO as soon as possible and doing it the right way?
Yeah, I don't think you ever get. You first have to identify that leader. So you are asking if a special course maybe for that leader would be beneficial. Is that?
Yeah, it's sort of a special skill set. Do you think the leader should have some special skill sets?
In simulation, that's always the case, yes. And it's rarely so that the people are actually most senior are actually having that skills. that's a mismatch we see a lot. So the most senior one is actually being looked at as you're the boss. You have to manage the situation, and his skill set is actually not being a good leader. If you do a simulation quite a lot, you get and you do it with your specific teams, then you get that sense of who's actually being a leader, who has that leader skills, and use it. When I visit a simulation session in London, I was really mind-boggled that someone who couldn't lead was actually not corrected by someone who actually could do that very well. And the team actually had some trouble in in correcting this. I think leadership skills you can train them, yes, but they're also natural leaders. And if you have a natural leader in your team, it makes sense to use that natural leader in your team and to enhance his capabilities. So to put your question is to answer your question, I don't think you can just learn how to lead these kinds of difficult situations by doing a different training. I think you have to look at your team, who's actually a good leader, who can manage this actually quite well and enhance that training. You can also look at shifting leaderships, where maybe not the most people in charge are leading, but a nurse or a resident. But maybe that answers your question a bit.
Yes, I think it's very important what you're saying, because you don't know who's on call when that happens, right? Who's the team members will be present on an ECPR situation. So I guess there is some I would say that there will be some skill sets which should be generic, but some skill sets which should be specific for a leader, and it can be very challenging. You have to decimate the hierarchy gradient. You have very many different people. You can have more than 20 people at the bedside when you're trying to put a patient on ECMO. And I think these sorts of trying to sort of prioritize, trying to see what is that and take out the noise factor. That's another skill that one needs to have.
If you ask teams, they always know which leader they prefer. They can name you the leader they want. And if you have such a difficult task as ECPR, that's, I think, one of the most difficult ones to manage as a leader. Should we do that in a general team? So is everybody which is on your staff capable enough to lead an ECPR? That's a really difficult question to ask. Has logistic problems, so it's not on call always. But it's sometimes a difficult question to ask. And ask your team; they will surely know which leader they prefer or which leader they. And that's a difficult, sometimes a difficult conversation you can have in your team.
Can I bring it back to the really interesting answers there? Can I bring it back to the question from the audience that Adrian has asked a really good question about candidacy for ECPR, and that I suppose brings in the question about training for those difficult questions, as well as the actual clinical aspects that Malaika and Aparna picked up. And how do you decide candidacy for ECPR, and do you practice actually making those decisions as a leader or as a team? So there's a specific question that Adrian had asked about, do you support ECPR for single ventricles? We've got 5 or 4 experts around the table. What do you think? For single ventricles, would you support ECPR? I'm doing a straw poll to you guys.
We do ECPR single ventricles, yes, especially I mean, as I have mentioned in my talk, they are very challenging, and of course it's a difference if you have a witnessed arrest in the ICU and you do ECPR with that, or a patient gets worse on the ward, or even comes from out of the hospital under pre-arrest conditions. But we do offer ECPR for single ventricles.
We refer those patients to Pete.
Yeah, then we lap them up. Yeah, we offer it too, depending if the conditions are right, but that is very difficult. And I find candidacy in ECMO difficult as it is in a pediatric cardiac patient that's sliding down the slippery slope. And what I would like to prevent is ending up in an ECPR situation. So we try to put the patient on before, but the timing is, I find, very, very difficult. When there is a resuscitation going on, it's fairly simple. We have implemented eCPR in our resuscitation flow protocol. So after the second adrenaline, there's a pop-up that says eCPR question mark. So we at least think about it and then discuss it and make sure we activate the team if we want to. So it's in our, for all our in-hospital arrests, it's available to consider. Yeah.
And I think the important, sorry, yeah, PT, go ahead.
No, I'm done. I think, no, go ahead. I think you finish this off and then we will wrap it up. Please,
Yeah.
Malaika, finish.
I don't think it's the problem is going onto eCPR for a cardiac child, a single ventricle, not single ventricle. You always have to ask yourself the question, why am I in this situation and where do I want to go? So if you have a child who needs to go under eCPR or pre-eCPR onto ECMO, then the next step would be, why are we here? Do we have to go to cath lab? How can we solve the situation? Because going onto ECMO hasn't saved a child's life yet completely alone. So that is the most important part. And this is what we do. This is why we offer it. We say, okay, we give it a chance. Then we try and sort out what is the underlying problem. Can we fix it? How can we fix it? Or if it's futile, it may end up in withdrawing the support.
I think those are very wise words.
Just one comment I'd like to say is that I think in a cardiac intensive care unit, I think it's always good to anticipate these issues. And I think sort of, think ahead, if this child were to arrest, would this child be a candidate? And, do we have the right resources? Is the access okay to offer that support if the child were to need it? And I think if there's one message I'd like to really emphasize is anticipation of the situation is far more beneficial than, sort of trying on the hop, trying to get all these services done instantly. Absolutely.
I think we should wrap this up. I want to thank the speakers and my co-host Mark for their wise words and the lessons we've learned. There's still a lot to learn, and we can learn this by ongoing discussions or by going to virtual meetings, which on the 5th to the 7th of May, there's a virtual EuroELSO meeting where we will discuss this and other topics as well. So thank you again for your participation. Thank you again for the speakers, and we hope to see you at the next EuroELSO webinar or at the EuroELSO virtual congress. Have a nice day all.
Bye-bye.
Thank you. Bye.
Bye-bye.